So liver cancer is unique among the malignancies we treat, really because it's two diseases, clinical diseases. It's a malignancy, and then it's a malignancy that occurs in patients who have another competing risk for events, which is underlying liver disease and cirrhosis. Historically, drug development for advanced disease in this area has ignored the underlying liver disease. And I think that's been part of the challenge in getting drugs successfully developed. Then comes along sorafenib, and sorafenib's clinical development was done very carefully in that they selected patients in which they could minimize the effect of the underlying liver disease. That is to say, patients who had advanced liver cancer but had well-compensated liver disease. Using the Child-Pugh score, these would be considered Child-Pugh A. And in that frontline study, the SHARP study, they showed an improvement in survival of sorafenib versus placebo. And that's now been 6-7 years since that data has been presented, and no other drug's been approved in liver cancer. There's been several phase 3 studies that have been launched head-to-head, including sunitinib, brivinib, lenifinib, and the combination of sorafenib and erlotinib. And none of those have shown to be superior to sorafenib, and therefore they've all been considered negative studies. Some of them have been inferior, such as sunitinib, but others have shown relative equivalence, such as with the brivinib data. But what it tells us, I think, is that this class of drugs, which are generally anti-angiogenic multi-kinase inhibitors, probably could have beat a placebo in frontline, but since sorafenib is the standard, it's been very hard to improve on that. And again, the data speaks for itself that for the past 7 years, we've had one drug that seems to improve survival.